when we take an objective cognitive skills test, it doesn't necessarily bear that out. And so we need to focus on kind of positive aspects of aging and positive aspects of the aging brain, because those negative emotions can actually do us some harm. And so aging may be generally characterized by slowing of cognitive performance, so and decrease in mental flexibility. So this might be, you see your friend at the grocery store, and she's coming your way, and you know her, and you know her, but where do I know her from? And our kids play together, and oh my gosh, she's getting closer, and I'm gonna have to speak, and then you turn and run the other way so you don't have to talk to her, right? And so you automatically think, oh well, my memory is failing, or I forgot her name. But then when you get in the car and you relax a little bit, her name pops into your head, right? Or when you lay down to go to bed that night, her name pops into your head. Well, that isn't forgetfulness. That's just a slowing of mental acuity. That ability of your brain to kind of think on its feet and respond to the situation. And we can expect some of that as the brain grows older, but we can also expect some of that if we're not using our brains as much as maybe we need to. So I spend a lot of my life like talking to people, doing things like this and responding to questions and keeping my brain active. And that's one of the ways that as we grow older, we can actually counteract that decrease in mental flexibility, is to commit ourselves to kind of a lifetime of keeping our brain active and flexible and all these other things. Now, one of the things that we can say about aging and in general is that, older adults, especially now more than ever, are maintaining their activities of daily living and their instrumental activities of daily living later into life. And so our activities of daily living are things like bathing, toileting, transferring, and then instrumental activities of daily living that are things that do to support that. So being able to go buy my groceries, being able to pick up the phone and make a phone call, being able to manage my medicines, kind of the things that we need to be able to do to live safely and healthily and independently on our own. And then also, generally characterized by retention of verbal abilities and vocabulary. Some of the things that we know and we know always remain with us as we grow older. So I'll talk just briefly about ADLs and IADLs. So again, these are daily living activities that we need to be able to do to live safely and independently on our own. And so when we start to suspect dementia, it is often when brain function, memory performance start to interfere with day-to-day life. And that deals directly with these activities of daily living, and specifically maybe our instrumental activities of daily living. So when a caregiver calls me or when a concerned person calls me, it's usually because mom is bouncing checks, or dad forgot to pay his electric bill, or dad hasn't taken a shower in a week and a half, and his hygiene is a mess. Some of these things that you and I probably do without thinking or without issue are some of the first cues that there may be something else going on when brain function and memory performance start to interfere with our ability to function in day-to-day life. And often where we see that most is in these instrumental activities of daily living. So when we talk about dementia, dementia is a broad class of diseases that generally include some type of progressive or advancing cognitive and behavioral impairments. Okay, so it generally, I mean, the origin of the word is kind of your mind is going down, is kind of where dementia breaks down etymologically. Now, there are many types of dementia. all the types of dementia are going to have a similar kind of presentation and a similar kind of set of things that we can expect. But they are all a little bit different. And the difference may determine how the disease presents itself. And sometimes that can be clues as to the type of dementia that we have. Dementia is not a quote unquote normal part of the aging process, but with something like Alzheimer's disease specifically, one of your number one risk factors, or the number one risk factor for developing Alzheimer's disease, is growing older. So while it is not a normal part of aging, advancing age is a significant risk factor. And it is important to understand through all of this, and we'll talk about this here in a bit, is that there are some other things that can be going on with us that look and smell and feel like dementia, but aren't. And so that's why it's important through all of this that when and if you start to suspect that there is something going on, when and if you start to suspect that there may be an issue, you need to be talking to your health provider about this. Often we don't want to share something like a memory issue with our health provider because we assume that they're going to immediately take our keys away and say we can't live by ourselves and all of these other things. But the reality is it's only through a thorough investigation about what's going on and thoroughly ruling out what else may be there that we should get to a diagnosis of dementia, because there are other things that can look like it that may be treatable and more manageable. So just a quick breakdown. We kind of skipped over the middle part, but that's okay. We'll give me a pass on that. But just to kind of break it down, so our aging process, we may expect that our body and brain may gradually slow, but that our intelligence remains relatively stable. And so that's the example that I provided you of the woman in the grocery store. In the moment, I had forgotten her name, sure, but I thought of it later. It came to me later. And so that shows me that my intelligence is relatively stable. My functional ability may be slowing down a little bit, okay? And that, another way to think about that is it's not where it's not that I forgot where I put my keys. It's that I don't know what my keys are for, it's not that I forgot where I parked. It's that I forgot I drove. So think about it like that. Now it's no less frustrating that you can't find your keys or you forgot where you parked and things like that, but give yourself a little credit for the fact that eventually that comes back to you. There's kind of an in-between between an aging brain and say dementia, and we're going to call that mild cognitive impairment. And so with mild cognitive impairment, we might expect some problems with memory or other brain functions, but it's not sufficient enough to interfere with our day-to-day life. And so this may start to suggest that there may be something else going on, some kind of other bodily process, some kind of mental or emotional issue that's going on that's causing this, but it's not quite severe enough to interfere with our day-to-day life. But it's a little more significant than just episodic kind of forgetting things now and then. And then with dementia, we've got that range of disorders that's causing enough of an issue that it's interfering with our day-to-day life. So let's talk about dementia specifically. So the title of this is, what's the difference between dementia and Alzheimer's disease? So here we go. Dementia is a broad class of diseases into which Alzheimer's disease falls. So to say that another way, Alzheimer's disease is a type of dementia. All Alzheimer's disease is dementia, but not all dementia is Alzheimer's disease. Now, the reason that gets a little confusing is, as you can kind of see on the slide there, roughly like 70% of dementia diagnoses are Alzheimer's. Okay. And so, we start to use those terms interchangeably because Alzheimer's disease is the most common type of dementia that we see generally. And it's, the most common diagnosis. But just know that there are other types of dementia. So, for instance, there is a vascular dementia that someone may suffer as the result of a stroke. There are dementias that are related to alcoholism. There is a type of dementia that is similar to like mad cow disease, or in cervids, in deer, what we would call chronic wasting disease. There is a dementia component that is sometimes associated with Parkinson's disease. So there are a variety of dementias, and Alzheimer's disease is one of them. So I'm going to pause here for a moment and ask if anybody has any questions so far, especially related to that point about what the difference is between dementia and Alzheimer's, since that's ostensibly the topic that we're here to address. And while you're thinking of your question, I'm gonna wet my whistle with a little bit of coffee. So does anybody have any questions so far?
You can feel free to unmute yourself and ask the question if you need to.
Okay. Well, please know I'm ready for it. And I may not know the answer, but I will make something up and you will believe that I know the answer. But please do ask your questions. And then, if it's not something you want to ask in front of the group, or if it's something you think of later, Sanja is ready and available to get that question from you and pass it along, and we'll get you an answer. But I am sincere when I tell you, we want to hear your questions.
I have a question.
Oh, please go ahead. Tell me your name.
This is Lady Trish.
Hello, go ahead.
I have a cousin that has Alzheimer's. Is it hereditary, and is it preventable?
Okay, so those are two great questions, and I'm sorry about your family member's diagnosis. So is it hereditary? Is it preventable? So the is it hereditary part, again, your number one risk factor is advancing age. There is about a 10%-ish link to a family history in what we'll call run-of-the-mill Alzheimer's disease. Alzheimer's disease that we would expect in someone, say, 65 or older. If we're talking about early onset Alzheimer's disease, which is Alzheimer's disease that we would expect with someone, say under 65, and let's go ahead and say under 60, more like 55 to 60 or less, there's about a 40% linkage there with a family history. So, certainly genetics plays a role in Alzheimer's, like it does in a lot of things. But at least with, again, like run-of-the-mill Alzheimer's disease that occurs in people 65 and older, it's a less significant risk than with early onset Alzheimer's disease. Your second question, is it preventable, is an interesting one, because more and more the literature is showing that a healthy lifestyle, managing chronic conditions, getting recommended levels of physical activity, watching your diet and things like that, can help reduce our risk. So prevention is probably a strong word, but here's the thing with Alzheimer's disease specifically. It's been with us for a long time. It's just that Dr. Alzheimer did his work in the early 1900s, and that's when we got a name for it. But previously it would have been called like senile dementia or hardening of the arteries or organic brain disease or something like that. Alzheimer's has been around a long time. The thing with it now is we're living long enough to get it, and we're living long enough to get it in significant numbers in the population. And so if through a healthy lifestyle, we can maybe slow its progression or find, a treatment that slows its progression enough to where we're dying from other causes before the disease has a chance to set up, then, we get back to the place we were, say, 100 years ago, where someone's heart gave out potentially before their mind did. Or they, died from some other cause before the disease had a chance to kind of show itself in their brain. So the quick and dirty answer to can it be prevented is no. But we do know there are some factors that we can engage in through our lifespan. Again,
Andy, we can't hear you.
Did I go away?
Yes, you're back.
Okay. Now I lost my train of thought, but that's okay because I'm not worried about it. Engaging in a healthy lifestyle, managing your chronic conditions, getting your physical activity, keeping your brain active can help, reduce a risk, but probably prevention, like I said, is a strong word.
Okay, the reason I'm asking because my cousin, she always did have a healthy lifestyle, but her father had Alzheimer's and her mother also. And now she has it. And as I look back, I could now see where it was coming a while back, because she's had it, progressively for about, I'm going to say about 10 years now. But before then, if I look back, I can see some of the things that she did that was a trigger point, but I didn't know. Like
it's a lot easier to kind of see in retrospect. So both my grandparents had dementia. Mm-hmm. And, there are little things now that you look back and you say, well, of course, now I see it. Mm-hmm. There are genetic markers that they could look for in your cousin that may show that hers is, more linked to heredity than it is to advancing age. And so, all the more reason that when you start to notice symptoms to talk with your health provider, try to get that diagnosis. I don't know, from an individual perspective, I don't know, like, there's a big ethical debate about genetic testing, especially early on, because, for a disease that is chronic and progressive and degenerative, sure, knowing in advance maybe that you have a risk for it helps you plan and make arrangements and all these other things. But, I don't know that it satisfies you in such a way that, okay, well, I have this diagnosis and now there's a treatment protocol that I can go into that's going to cure me. But certainly, like, for curiosity's sake, that type of genetic testing is available.
Okay.
But thanks for the question. I hope that got you some information, if not an answer.
Andy, this is Sandra. I have a question. It's kind of
okay.
So when I want to think about how do you approach it when you see a parent having symptoms of dementia with the forgetfulness and all this, but at the same time, HIPAA laws prevent you from speaking with the doctor because the parent doesn't see or doesn't think that they have an issue with forgetting things, but you see it as their child. Do you have any recommendations?
I think there's some ways to go about that. That includes something like, hey, Granny, I've noticed that, forgetfulness may be causing some issues here, or, not in a threatening way. So anytime we talk about like working with caregivers to address issues with their care recipients, we always emphasize using I messages rather than you messages. So, because a you message is an indication or is an indictment or an accusation or something. So, Sanjay, if you were to go to someone and say you need to talk to your doctor about memory issues, then the gist of that is you have a problem. Whereas if you go at them and say, I've noticed X, Y, and Z, then that's framing the situation from your perspective. And they may say, oh, no, baby, I've just been stressed lately, or something, or maybe they say, I have, and he told me not to worry about it, or something like that. As far as like communicating with the provider, I think that's an area where you talk to your loved one and say, I would like to go with you to your doctor for support, or I would like to go with you to your doctor, to help, or something like that. And then that's the opportunity to say, hey, Mom, have you ever mentioned to Dr. So-and-so that, you are having trouble managing your medication, or that you're making brownies with salt instead of sugar, or something like that. And in that way, it kind of innocuously starts that conversation. But it is a tough thing. I think the other thing, especially like with HIPAA, Sanja, is that, the you contacting the health provider about a concern is probably less iffy with HIPAA than them calling you and saying, hey, Sanja, your mom's off her rocker, or something like that. So, that providing information to the provider is probably less worrisome than them giving you information outside of the patient's permission.
Thank you, Andy. That was great.
No worries. So Barbara says, my sister has the beginning of dementia, remembers a long time ago, but doesn't remember short term. She remembered bits and pieces of what she eats for breakfast, but not for lunch. And so that's one of the hallmarks of Alzheimer's disease specifically, is that it sets itself up in the area of the brain. We're approaching 30 minutes, and I'm just going to stop presenting and start talking, because we're kind of getting to a place here where I like where the conversation is going. And then if we need to get back to my presentation, we can. So one of the ways that, or the Alzheimer's disease sets itself up initially in the area of the brain that's responsible for taking in and processing information that we receive from our senses. So, on a good day, our brain takes in and processes or decides to reject anything we see, touch, taste, hear, or smell. And if you think about it, our senses are the only way we experience the world. We either see it, touch it, taste it, hear it, or smell it. And so with Alzheimer's disease specifically setting up in that part of the brain, it impairs our ability to take in and process new information. It does not, however, at least in the early stages, interfere with our ability to recall information that we already have. Now, sure, later in the disease, as it becomes more rampant through the brain, there could be problems with memory retrieval, or pulling out old information, but at least at its outset, Alzheimer's is not a disease of forgetting, it's a disease of not being able to take in and process new information. So one of the reasons that's not one of the reasons, that is the reason that your sister may be able to tell you something that happened 30 years ago, but can't tell you what she had for breakfast or lunch. That part of her brain that lets her take in and process new information is not functioning properly. And then as the disease progresses through the rest of the brain, it may interfere with our ability to speak, or our ability to hear, or our ability to see and understand, or some higher level executive function like, well, I live in Amarillo and it gets cold here. I mean, we get 20, 30, 40 inches of snow a year. And so, there are some aspects of dementia, especially as the disease progresses, where I know I need to get dressed to leave my house, but I might put on shorts and a t-shirt to go out into the snow because I'm not able to do that higher order kind of decision making. So I hope that gets to the issue you were bringing up about your sister. One of the things that it's important to understand about dementia and specifically maybe Alzheimer's disease, our brains are very compartmentalized. We only think about our brain as one thing, but it's like a pot of soup is just one thing. So you make soup or stew at your house and it's just one thing. But if we think about it, what is soup? Well, there's a liquid. There's probably a variety of vegetables. There's a variety of seasonings. There's probably, if you make soup like I do, there's all the leftovers that you don't know what else to do in your refrigerator and you just throw it in the pot because it makes it all better. And so if we think about a soup in its constituent parts, that's what our brain is. Yeah, it's just one thing, but there are a variety of constituent parts. So there's an area of our brain that lets us hear things and turn it into a thought. And there's an area of our brain that lets us think something and turn it into a word. And there's an area of our brain that lets us take what we see and turn it into a thought. So, your brain on a functional level isn't just one thing. And that's why with all types of dementia, and since we're talking about Alzheimer's specifically, it looks different in different people because it can take up shop, it can cause problems in various parts of the brain, and the symptoms that manifest are directly related to the areas of the brain that are being affected. We've worked with people with Alzheimer's disease who, want something to drink and they desperately want water, but all they can say is milk because the area of their brain that lets them convert a thought to a word isn't functioning properly and they can't come up with water. And so they say milk, and you bring them a glass of milk and they're angry because they didn't want milk, they want water, but water just won't come out. And that causes agitation and frustration and all of these other things that can cause that situation to go off the rails, and it's through no part of anybody's own. It's just that the brain isn't working like it should because of the area that's being affected. The other thing that's important to understand about many types of dementia and Alzheimer's disease specifically is it is actually a physical cause to a mental disorder. And this is one of the things that Alzheimer kind of was unique when he was doing his work, as he was the first clinician to ever put a physical cause to a mental disorder. Previously, people thought that if you were having issues with your brain, it was a chemical imbalance or an electrical imbalance or whatever. But what Alzheimer actually showed was that the disease was destroying the brain. And when I do trainings for residential facility staff, especially like skilled nursing staff who are working with Alzheimer's patients, we actually show pictures of a healthy brain and an Alzheimer's brain to look at the atrophy, to look at the missing pieces that just aren't there anymore. And so if you are in a caregiving situation, or if you are, working closely with someone and there are days when you tell yourself, oh, they're just having a bad day, or this is the conversation that we had to have with my grandmother early on in her caregiving journey before her dementia kind of got the best of her, is she would tell herself that granddaddy was doing things on purpose, that he was, putting his Cheerios in his glass of water on purpose, or that he, called her a bitch on purpose. And the reality is it's not. It is not like that, but it can be hard to tell yourself that when the reality around you suggests that perhaps they're just kind of messing with you that day. So I promise I'm going to wrap up soon, Sanja. I promise I will. So let's talk very quickly about diagnosis, and then let's talk a little bit about some things that maybe we can do, and then you'll have to have me back for, to finish the rest of my presentation. So diagnosis needs to happen early. And in order for that to happen early, we need to be talking open and honestly with our health provider when we notice these little things happening. And he or she should not just like look in your nose and look in your ear and look down your throat and say, OMG, it's dementia. It should actually be a pretty thorough evaluation where we're doing some physical assessment, maybe some imaging, like an MRI or another type of scan. And the MRI isn't necessarily going to show Alzheimer's disease, but it can help rule out, say, a tumor or some swelling or a blood clot or evidence of a stroke or something like that. So it's part of ruling out what else might be going on. And then also maybe some laboratory tests to check, say, blood sugar levels and thyroid levels and all of these other things, because there are some of those metabolic imbalances or disorders or endocrine disorders that can actually mimic symptoms of dementia, and it's important to rule those things out. And then, of course, there are some cognitive tests, and this has gotten, well, I won't go there, but anyway, the cognitive tests are kind of a snapshot in time to see how your brain is functioning, and usually there's some kind of element that tests your memory and tests your language skills and tests your orientation to time and space. So they might ask you like the date, and they may ask you, who the president is, and they may ask you to remember some words, and we're going to come back there, and they may ask you to count backwards from 100 by 7. But these are not perfect. So for instance, one of the common questions on one of the instruments is spell world backwards. And so, in order to do that, your brain kind of has to spell it forward and then take it apart and spell it backwards. So WORLD, DLROW. See, I'm good. But there's a little bit of manipulation that has to happen there with that. But that assumes you could spell world to begin with. Okay, so there are some inherent biases in some of these cognitive skills tests that say maybe assume you graduated high school or completed the 3rd grade or something. Non-native speakers of English sometimes have trouble with these cognitive skills testing. One of the big areas of research right now is we know that persons with Down syndrome have an increased risk for developing dementia. And so what is talking to someone with Down syndrome, what does a cognitive skills assessment look like with that person? And so there are some other tests that are coming up, that are gaining more credibility, that are more visually oriented. So the identifying pictures, and there are some of these that are graded differently based on if you completed high school versus didn't complete high school. And so, it's funny because I follow the news a lot, and in recent weeks, there's been a lot of discussion over cognitive abilities of 2 probably very important people in the next 60 to 70 days in this country, and they're holding it up like, oh, look, I passed. And it's not really like that. It really is just kind of a snapshot in time, and it should be viewed in the context of a variety of other things that go into testing to make some kind of diagnosis. I'm going to talk briefly about two things that may be, well, one may be new to you and one may not be new to you. So there are a couple of conditions that mimic dementia, but are not dementia. And one of those is known as delirium, and one of them is depression. So delirium is an altered, fluctuating state of consciousness that can include forgetfulness as a symptom, but delirium is actually a medical emergency. So what causes delirium? Well, an infection might cause delirium. Specifically, what we see with a lot of older adults is urinary tract infections can cause delirium. Temporary confusion that is kind of a sudden onset. Okay, so if we think about dementia as being kind of a gradual decline, and I think we talked about this with Lady Trish a minute ago, where she said, if I look back, I can see it coming on, but I didn't notice in the moment. And that's kind of that gradual decline, that stair step down into Alzheimer's disease. But delirium is more like I'm fine 1 minute and I am not the next minute. Okay. So what else could cause delirium? Well, where I see delirium a lot is with placement in a nursing facility. So if Great Aunt Tilly lives out on the family farm, and until yesterday, she was milking goats and baling hay and doing whatever else Aunt Tilly did on the family farm. And then she breaks her hip and has to go into a facility. And now all she does all day is lay in a bed and stare up at acoustic tiles or watch reruns of The Young and the Restless, because in case you were wondering, due to COVID, they can't make new episodes. Not that I know. That is a change in her environment that is causing her to not have to, quote unquote, struggle to make her life day to day. She's not having to fight for anything. Her environment isn't making her function at a high level. And so guess what? She doesn't function at a high level. And she may end up with temporary confusion that's based only on a change in her environment. So delirium is actually is quite serious, and we need to pay very close attention to it. And it is a medical emergency. It needs to be rectified, whether it's an antibiotic or getting a thyroid level back in check or regulating blood sugar, or just stimulating Great Aunt Tilly in the rehab facility so that she's challenged day in, day out. It's very important. Depression we're going to describe as kind of a decreased mood or depressed mood, or a loss of interest, or things that brought you joy or sad, or experiencing sadness for a period of 2 weeks or more. And depression is actually quite common in older adults. But the good news is depression is absolutely, positively, generally very easy to treat through some combination of a cognitive or behavioral therapy or a medication. Now, often there's a reluctance among older adults to talk about depression, to talk about depressed mood, because we stigmatize that as some type of weakness, or there's a throwback to not the institutionalization that may have happened in the 50s and 60s that we experienced growing up, and now that's what I associate into my old age. But just like I would talk to my health provider about a cough or a sneeze or an ache or a pain, depression is no less serious and no less treatable in many instances. And so I would really encourage you to be open and honest with your health provider about feelings of depressed mood, sadness, loss of interest. Many of the symptoms of depression are also somatic. So it might be sleeping too much or not sleeping enough, eating too much or not eating enough, nausea, anxiety, all of these things. Talk to your health provider about those. Don't just write them off, because again, it is generally very easily addressed through some form of therapeutic intervention. And oh, by the way, just to complicate, yes, Jesus, take the wheel, absolutely, and steer me on to my health provider so that I can get treatment for my emotional disorder. Oh, by the way, delirium and depression can coexist with dementia, which, absolutely exacerbates and complicates things. And I know that when Granddaddy would get a urinary tract infection, you could tell a difference. So sure, he's still existing in that dementia plane where he's having symptoms and having issues and all of these other things. But I mean, it is just like you went off a cliff with his behavioral issues, and incoherent speaking and all of these other things. And that was a clue that there was something else going on there. And sure enough, he would end up with having a UTI. My grandmother is a little bit different. Granny struggles with depression that exists with her dementia. And some of it was related to his care, but she would actually experience mania where, she's way up one day and she's way down the next day, and way up one day and way down the next day. And so through some changes with her medication, we've been able to level that out for her a little bit. I'm going to put one more slide up and then I promise I'm done, Sandra. I promise I'm done. But I'm glad to answer any questions that you might have before I go. So let's look at just some general strategies for care and well-being.
I have a question.
Oh, please go ahead.
I was always concerned. My dad has since passed on, but I was always concerned when they said he had dementia, which I also thought was Alzheimer's. I don't understand why at the VA they would talk to my dad. And I know he was the patient, but he had no idea what y'all are talking about. So I don't know if that's just doctor protocol, but I found it off-putting because they always would talk to him. And I'm like, we're the ones who got to interpret. We're the ones who have to get him through this. And they would talk to him and wait for him to answer. And I'm like, he doesn't know what you're talking about. They put their hand in his mouth, he'd bite them. So to me, they should have known that he is not coherent, and they would continuously talk to him as the patient and not even turn their head and look at us.
So I think you hit the nail on the head there. And is it Kay? Can I call you Kay?
That's fine.
Thanks for the question, Kay.
Beautiful works too.
Oh, okay. So I think you hit the nail on the head there with the health providers and helping professionals. So whether it was the social worker or the pharmacist or whomever, they're trained to do that, to address the person, because there's actually evidence that when we take away dignity and autonomy and independence, we actually threaten the well-being of the individual. And so, as frustrating as it might be for, you to sit there as the third party and need or want to interact with the health provider to ask questions or to get information or whatever, the health provider is operating from a frame of your dad is his patient or her patient, and so I am there to be with and for him. Now, I think there are ways that we can work around that. So, maybe we go into the room with the frame of, I know he's going to talk to my dad, but here's my list of questions. And so before he has an opportunity to walk out the room, which, is fast, hey doc, I have a few questions, please. And so it's a tough needle to thread, because they're sitting there knowing that, or they've been trained to interact with their patient, and to try to get the story from him or her. And it is frustrating. And I do the same thing. So I'm telling you what the book says, But when I go to a doctor's appointment with Granny and she's telling the doctor, this and that and the other, I'm in the corner going no or yes or something like that. But that actually threatens my grandmother's well-being a little bit because, it would be a shame if the doctor started to disregard what she said based on what I say. Because then, we're in a situation where I'm taking away her independence a little bit. So I hope that helps. It's not an easy answer, but if it gives you any hope or reassurance, even people who know what's supposed to happen don't do what's supposed to happen.
Thank you.
So let's talk about some things that we can do, and then Sanja, I promise I'm done. So priority, clinical diagnosis and intervention. Talk to your health provider about suspicions. Talk to your health provider about symptoms that you're experiencing, to the point that we had with Sanja earlier where she was like, how do I bring this up? Find ways to meaningfully and thoughtfully and carefully bring these things up. And one of the best ways to do that is focus on I messages. And not like, I've noticed that you're nutty. Let's be very sensitive about this, but I'm concerned for your safety, okay? Or I would like to go to the doctor with you to discuss X, Y, and Z. Try to focus on people's current, not prior skills. So when we were talking earlier to Barbara about her sister and not being able to maybe remember what she had for lunch, not that Barbara does this, but try not to focus on, not remembering what she had for lunch, but let's go ahead and talk about what she can remember and experience life with her in that place. Try to simplify tasks. So if you're a caregiver for someone with dementia, rather than taking them to the closet and throwing open the door and saying, what do you want to wear today? Maybe go in there and get the red shirt and the blue shirt. Do you want to wear the red shirt or the blue shirt? Do you want a ham sandwich or a turkey sandwich? Something like that, because then you're still providing them an opportunity to have some independence and autonomy to make decisions, all of these other things. And, if you say, do you want to wear the red shirt or the blue shirt? And they say Buick, well, then you tried. And as the caregiver, you can go on about your day and say, at least I asked, or I gave him or her the opportunity to come up with what they wanted to wear. Don't forget physical activity, especially if you're a caregiver. Being out in nature can be restorative. Get physical activity, and to the extent that the person that you may be caring for can participate in physical activity, it's great for them too. Go let the breeze blow through your hair. And Sanja, yes, I will go dancing with you. Thank you for asking, but you have to teach me how to do the wobble, because I saw that on TV the other day, and I'm now convinced that that is my goal in life, is to learn how to wobble. Recognize environmental influences that may be going on. So, if mom just moved into a new place and is temporarily confused, that may be an external cause that we need to address. And then watch for like overload and sensory stimulation. It's good to stimulate the person, but sometimes it can be too much. And so try to keep things as simple as possible. And then just some key takeaways from our day-to-day. Most forms of dementia come on slowly and can be preceded by a period of mild cognitive impairment. So we're kind of advancing from it's kind of okay to it's interfering with day-to-day life. Alzheimer's disease is the most common form of dementia, but it is not the only type. And so remember that to the extent that it's a distinction and a difference. And then just also know that dementia is not the only cause of memory issues. So autonomy, the ability to function independently, the ability to kind of self-determine, to make our own way in life, we are autonomous beings, autonomy. And when we lose our autonomy, it threatens our independence and well-being. It really does. Julie has a question, but go ahead and ask it, and then I've got to be quiet because there's another speaker.
My question is, my mom has dementia. She's been diagnosed by her physician. The problem with my mom is she becomes extremely combative when we want to take her to the doctors, or we need her to move by my brothers, and she refuses to let go of what independence she feels that she has left, but she is not in the right mental state any longer. But we can't go in and force her to move, because I think that would do more harm than good. And she's since had 2 strokes on top of seizures, on top of her dementia, on top of her diabetes. So at this point, we don't know what to do right now.
It seems like there's a lot going on, and
Yes,
you know, it's about finding that acceptable level of risk. And so, you know, if you think about her life in her current situation, and you know, if she's reluctant to make a change, or you and your siblings are reluctant to make that change for her, then it really is about, let's go in and find out how we can create an acceptable level of risk for her to continue to live independently. And whether that's exploring, you know, community care attendance, or services that may come in to do custodial care, or bringing home health in, or something like that, working with her provider to determine if she maybe qualifies for hospice at this point. I don't know the situation, but explore all your options. The other thing that I would say is take that communication piece to heart. Mom, we are concerned about safety. Mom, we worry about X, Y, and Z. And so again, I don't know what to tell you specifically in this moment, but let me provide you with this anecdote. So my grandparents were absolutely positively resigned to not leaving their homes, even when a more supportive environment would have benefited them greatly and taken a lot of stress off my dad and his 2 siblings. But what that ended up looking like was a series of progressive conversations with my grandparents, some of which they were not able to, say, functionally participate in, about bringing more and more care into the home, up to and including hospital beds. So, you know, it may be, hey, Mom, we're willing to, you know, respect your wishes to remain in your home, but in order to do that and to guarantee safety, let's talk about these 5 changes we're going to make around the home, and see if that doesn't ring a bell. Now, you said that she's experiencing dementia. You know, that this may not get you anywhere.
Right.
Also involving her health provider, to the extent that he or she is able to be involved, you know, to make sure that treatments are everything they need to be, and medications are everything they need to be, and recommendations maybe for home health or other services that may be able to come into the home and help. You know, this is where being a caregiver is a little unfair sometimes, because you're having to play both sides. You know, you're having to be offense and defense. You're having to think about what you need and what your mom needs, and that can be a struggle sometimes. But if there are things that we can do to help you, please let us know. But I would say, you know, a united front with your siblings, open and honest communication with your mom in a non-threatening manner, and then working with her health providers to make sure that you know, all the benefits and services that for which she may be eligible, you're taking advantage of.
Okay. All right. Thank you, sir, so much.
All right, thanks, Sanja. And I'm going to stay on in case anybody has questions. And I'm so sorry. I never in my life intended to go that long.
It's okay, Andy. You did a great job. It was just really great how you broke some things down and you provided scenarios. And I'm going to project now for Anna Duran. I'm going to allow her to introduce herself, but I am going to share her slide. So,
thank you, Suja.
Okay, does everyone see the slide?
I can.
I do, yes.
Okay, go ahead, Anna.
Thank you to Dr. Crocker for all of that, fabulous information. I just want to give a quick thank you to AgriLife for giving me the opportunity to speak. I work for Kelsey Research Foundation, and along with the Baylor College of Medicine and the Alzheimer's Association, we're collaborating on a research study called US Pointer. So if you take a look at this slide, US Pointer is basically, it's a 2-year study. And we are looking to protect brain health through lifestyle interventions. So I see that there was a lot of emotion about, some of y'all sharing about your family history. This addresses part of what Dr. Crocker was sharing regarding healthy lifestyles. So this is a 2-year study, and it's covering 4 different domains. We're looking at nutrition, also some cognitive social stimulation, physical activity, and self-health monitoring. So those are the 4 domains that we are taking a look at. Sonia, if we could have the next slide, I will give you a little bit of information on who's eligible. So here's the criteria for who can join our study. We're looking for folks between this age range, 60 to 79. And part of it is we want people who are not regular exercisers, since that is a part of our intervention implementation. And the third component of that is, are there other factors that you have, like family history, mild issues like high blood pressure, cholesterol, or blood sugar? So those are some of the other risk factors. This is the kind of our ideal candidate. And if we'd want to do our next slide, I will give you some information on, how we can move forward. So if you know someone who is interested, they're not sure that they meet that criteria, that top number, it's the 713-798-5452, is a direct line to Baylor College of Medicine, and they are doing the medical component for us, doing the screening information. That second area, that is my name, my phone number, and my email. So if you have questions, I would be happy to, to answer them for you. And that is all that I really have to share today. Do we have time for questions, Sonia?
Yes, but I do need to give a disclaimer. I forgot to give it before you started.
Absolutely.
So Anna is with Kelsey Seabold, and we are with Texas A&M AgriLife Extension. And as Extension, we are not recommending or endorsing the project that she's working on, but we did see it as an opportunity to share information. So I wanted to make sure I gave that disclaimer.
Thank you.
And we do have time for questions. I mean, we try to limit these to an hour. But I mean, if the discussions are good and people have questions, we definitely want to take time to answer those. So if anyone has questions for Andy or Anna, please ask.
Are they online, or is it, do you have to come to the class?
So due to the COVID situation, we are starting our program virtually. So for at least the first month or 2, we will be holding classes virtually. And then the plan is to transition to in-person classes.
Okay, and is there a cost to this?
There is no cost involved to you. If you call the number directly to Baylor, they can give you a little bit more information about the specifics, but there's no cost to participants.
And what number is it for Baylor? That first number above your name?
Yes, that's correct. The one above AD prevention.
Okay. And when will it be starting?
We are ongoing and we are recruiting. We are going to be continually recruiting. It is a 2-year study. So we are looking for a 24-month commitment. We will start the program when we when we form teams. So a team needs to consist of at least 10 other people who have met the eligibility criteria. And our teams are forming all around the Houston area.
Okay, sounds very interesting.
Thank you, Barbara.
So in the chat, Susan has provided the link for our Qualtrics survey. And I do ask that everyone please go and complete the survey. I see there are some great comments, and like if you want us to provide topics that you're interested in, this is how we find out what topics you are requesting. So please complete the survey. It's probably 5 questions, and another one just to ask what kind of topics you're interested in. Also, we are hosting diabetes classes beginning September the 8th through October the 1st on Tuesdays and Thursdays at 11 o'clock. Hopefully we're going for about less than an hour, but who knows? We like to talk and engage, and that's just fine.
Is this the same class that you've had over at Dawes Park?
Yes, ma'am. This will be Wisdom, Power, and Control, the same one. And it's like a refresher because you know that class is normally 2 hours for 6 weeks.
Yeah, I know.
So
I'm usually there when you've had them at Dawes.
Yes, ma'am. So we're condensing it down to 8 sessions of 30 minutes or somewhere around there. So if you know people, please have them go register. Susan will send that link out again. And if you need the registration process, you can email Susan or call her at 713-274-0968. And I will put that in the text.
Okay, thank you.
So remember, September 8th through October 1st. And this time we are also offering CO Puedo, which is Spanish. So if you have Spanish family members or friends, they will also have the opportunity to gain this information related to diabetes management. My coworker, Amanda, while I'm teaching it in English, at the same time, she will have another link teaching it in Spanish. They will be delivered virtually, just like this platform that we're using right now. So,
okay.
You know, I just heard on the news this morning that, you know, with the pandemic going on, it's important that individuals manage their diabetes as best as possible. And that's a way to learn how to manage it, how to eat healthy, how to take your medications correctly. And when you say eat healthy, count those carbs and understand what are high carb foods and what are low carb foods, and how they impact your blood sugar. I love teaching diabetes. So next week, you all get a break from us. Unfortunately, we have mandatory training. So we will not have a Wellness Wednesday class next week. So you get a break, but we will return on September 7th with a coworker. I don't know what, no, it's the 9th. I'm sorry, September 9th. It will be disconnect to reconnect. We're using all of these different platforms. We're using Teams, we're using Zoom, we're using GoToMeetings, Facebook, and one of my coworkers, he's going to present on just, you know, how not staying on Facebook, you know, 8 hours a day and, you know, sacrificing your family. So, and then
okay, now if I can't
learn about that blue light. Learn about how that blue light impacts your life and, you know, ability to go to sleep.
I can't get there to the first meeting or so because I'm in the process of setting up to have back surgery.
Okay,
so
it's okay.
One,
yes,
yeah, I'm having one next week, the shots, and then I'm not sure when I'm going to have the actual back surgery, but it's coming up within the next few weeks. So, but I can come into it later.
Yes, you've gone through the class before, so you can contact Susan. You can contact Susan. I do want to say that individuals who attend, we're looking at if you miss 1 or 2 classes and you complete the pre and the post survey, we're going to provide can you all see this book? I got this background on and it's probably messing with it. Let me turn the background.
We still got the Anna's information.
Okay. Oh, okay. It's on my, let me stop sharing. Can you all see me?
Girls?
So let me try to get this book off here. Okay, so here's the book. It's called Choose Your Foods. So everyone who completes the pre and the post test and they attend 6 of the 8 sessions, then they will receive this book free. So this is a great book for individuals living with diabetes. Choose Your Foods. Food Lists for Diabetes.
What was her number again?
713-274-0968. The flyer is on our Facebook page and it has been emailed out.
I haven't gotten no emails yet.
Oh, okay. That's strange. Maybe Teresa C over there at Dossport. I'm sure she has
Okay.
it.
All right. Yeah, she does.
Okay. So I think I hit all the reminders. Please complete the survey. Register for CEO Puedo and Wisdom, Power, and Control. We will have orientation on September the 1st. And remember, next week, we will not have class on September 2nd.
May I add, Dr. Davis?
Sure.
Yeah, about the Wellness Wednesdays. Just like Dr. Davis stated, this is Tiana Donaldson. We will commence our Wellness Wednesdays on September 9th. We have a wonderful lineup based on the information you sent and those Qualtrics surveys. So we'll be covering numerous topics on life insurance, basic food preservation, Medicare, social security, just to name a few, home modification for aging in place. So we have a wonderful lineup. So we have a short break on September 2nd, but we will pick it up on September 9th. And we have information coming soon from Susan. So look out for that.
Okay.
Great topics. Okay. Please complete the survey. Click on that link. And always remember, if you have missed any of the Wellness Wednesdays, they are recorded and they are available for you to preview or review on our YouTube channel. So Susan will send that out as well.
How do we get that address or that YouTube number or name?
Susan, can you put the YouTube channel in the chat?
I will look for it. Barbara, do you want to give me your email address in the chat, or could you email it to me?
I can give it to you. I'll do it with the chat.
And then I can just start emailing things directly to you.
Yes, instead of through Teresa. Because we have a lot of senior centers or community centers, we send it to the person over that site and they distribute it out. But if you want to receive it directly, just place your information in the chat box and you will receive it directly.
Okay, I can't find the chat box on here. Is it the red box with the phone?
So do you see there's a bar and there's a hand, like where you raise your hand? You don't see it either?
No, down here it is. There's 2 people, and then right next to the 2 people, it's a little page like with some lines on it. That's the chat.
I think everybody's looks different if you're on a phone or if you're on a iPad or a tablet. So if you like, you can just call Susan. Just call her and give it to her. And I'm going to put it in there, 713-274-0968.
Okay, I got that.
Just call her, and if she doesn't answer, you can leave a voicemail, or you can call 713-274-0950, and Julie, who is also on here, she will answer. You can leave it with her.
Okay, so that second number, the 2 numbers is 0968 or 0950.
Yes, and the YouTube channel is also in the chat so that you can go in and view it at any time.
Okay.
And when Susan sends out, she normally follows up with an email. She will also include the link for the study.
Does she send it to Teresa?
I'm sorry?
Does she send them all to Teresa at Dawes Park?
Yes,
Yes.
ma'am, every week.
Give me a call and I will add you to the list so you get them directly.
Oh, okay. Now, who just said that?
That was Susan.
That was.
Oh, okay.
Sorry.
And Susan, you have another lady. There's another guest on the chat who provided her email. And like I said, honest information on the research study, we would email that out also.
Okay.
Well, I hope everyone is getting prepared for the storm.
We are.
A little tip that one of our coworkers shared with us: if you have Ziploc bags, fill those up with water and place them in the freezer. So, and then, you know, if you lose electricity, it will help to keep your frozen foods longer. That was a little tip I never heard of. So that's something I want to do. Fill those Ziploc bags up with water and just place them in the freezer.
Well, we do that now, but we do that for drinks.
Wow.
If they don't have the Ziploc bags, they can also use like the water bottles that they have. They can do that way also. If as they melt, that'll still give them their fresh water to drink.
That's good.
Yeah, and if I can add one more, if you can
Sure.
get rock salt, if you have a cooler, put rock salt over ice. It will stay cold for days, and you can add it. I give this information because I go camping a lot. But if you go have a cooler with some ice in there already, add rock salt, sprinkle it on the top, it will freeze. It's a freezer. So yeah.
Good idea. Salt.
I've been seeing this one about the washing machine also. You can put like water and ice in your washing machine, and if you can keep foods cold there, and the washing machine will automatically drain the water. So that was a new one I never heard of also.
That's a good idea too.
That's
a lot of smart people out there.
I didn't know that one. That is a good one.
Yeah, it's a lot we're learning. I guess this pandemic, we're just hurricanes and pandemics, we're learning a lot. Well, thank you all. And like Tiana said, we're going to skip September 2nd and pick back up on September 9th. And just everyone, please be safe. Just be safe out there. And if there are other topics that you want, please feel free to share those.
Thank you, Sonia.
And you're welcome. And it was good seeing everybody. And we will talk to you later.
All right. You stay safe.
Yes, ma'am.
Bye-bye.
Thank you.